We are live on Lagos Talks 91.3 FM. Very shortly, we will be live on Facebook. But I'm not here alone, hosting this alone. I'm being joined by my colleague, Olaoluwa Awe. Olaoluwa Awe, good morning to you.
Yes, good morning, Kaide. How are you? It's such a pleasure to be doing this. The whole of April, talking about health. You know, there was something I mentioned last time. At the end of this month, somebody must be healed. Someone must do better health-wise. Someone must start to live healthier life. And that is what we hope to achieve here with the April Health Month. And as you mentioned, we start with a webinar, which I'm excited to be about. I can't wait to really engage the long list of health experts that we have to have a conversation with today. The list here is quite impressive, from Dr. Oshundare Tope Zenith, to Dr. Uche Ngwaba and Professor Abimbola Akintade, even Pastor Peters Omoragbo. These are very, very impressive people with impressive portfolio in the health industry. And they are Nigerians, and a number of them are also Nigerians in diaspora. So we get to really compare the structure, the health structure we have here in Nigeria with what we have out there in the US and the UK, and how we can live up to that standard and even better. So that is what the conversation will be around today. Can't wait to start.
And even, shedding more light on the conversation, all this conversation, that's what we're going to have. But the ultimate aim is for us to make lives of the average Nigerian better. And that is what is principal to us. That is what is key, because as a radio station, we interact with Nigerians. We get feedback from Nigerians, and we do relate with the facilities in Nigeria. You realize that many things we call good in Nigeria, some of our speakers who've attempted to practice in Nigeria, some of them, they will share maybe at some point their experiences with us. They will interact with us, engage us, and let us know what really it felt like. I will try to understand the differences between healthcare in Nigeria and, of course, healthcare in the US, the UK, and Canada. And that is three places from outside Nigeria that we're bringing speakers from. Like you said, you've listed the names, and of course we have our own homegrown expert here, Dr. Oshundare Tope Zenith, who is the president of the Nigerian Association of Resident Doctors. It promises to be a great time. It does promise to be a great time. And for our listeners, you could join us right here on radio, like you're listening right now. And more importantly, you could go to Facebook to also be a part of the conversation. If you don't have the link, because the link is quite restricted to a couple number of people, you could also join us. Just go to Facebook and be a part of that conversation right now. Olaoluwa, about 3 hours of active participation, engagement, and policy realignment.
That sounds like fun.
Yeah,
it sounds like fun to me. And yes, the theme of today's conversation is primary healthcare and financing. And it's interesting to know that we get to speak with Dr. Oshundare Tope Zenith first today. And as you mentioned, he is the president of the Nigerian Association of Resident Doctors. He will be discussing reversing the healthcare migration trend, a serious issue affecting the health sector. Good morning, Dr. Oshundare Tope Zenith.
Yes, let's engage him partly right now. Dr. Tope Zenith, good morning. He's joined us already by Zoom. Kindly unmute yourself. Some of our speakers have actually joined. Dr. Tope Zenith, we can hear you.
Yeah, good morning, sir. Good morning, Olaoluwa.
Good morning.
Great. Thank you so much for your time this morning. And Nigerians are just interacting to see the participants that the speakers, those that they'll be engaging with. So you're here. Thank you for joining us. I believe Dr. Uche Ngwamba is also joining us already. Dr. Ngwamba, good morning to you.
It's a pleasure to be here. Thank you very much for having me.
Great. Thank you so much for your time. Those are the proud exports of Nigeria to the world. So when you hear of any innovation, especially legally speaking, in Canada, you need to check out to ensure, for all you know, it might just be Dr. Ngwamba that is doing the trick. So if Canada claims him, we will not accept, just to let you know, Dr. Ngwamba, we will not accept Canada to describe you as a Canadian of Nigerian origin. No, you are a Nigerian residing in Canada.
You're too kind. You're too kind.
Great, great. Our other speakers will be joining. Professor Akintade is actually in classes now. He will be joining us around 11:30 Nigerian time, West African time. And a lot more people will be joining. Just to Pastor Sarah or Moragmo will join us towards the end. He's in between some activities right now this morning. But just to acknowledge some of the other members that have joined, of course, this webinar put together by Lagos Talks 91.3 FM is not done alone. We're doing it in collaboration with Media Impact Initiative. That is a special purpose vehicle of Lagos Talks with which we drive, or the Mega Electrics Group, with which we drive initiatives trying to impact and influence events that happen in our great nation, Nigeria. And so through that, we have a couple of other people joining us, other organizations. We'd like to acknowledge the presence of Nigerian Diaspora Organization in Europe, and they joined us online. I saw that them join earlier on. We have members of Nurses Across the Borders International, and partners and members of Nursing and Midwifery Council of Nigeria. We will run through some of these names as we continue with the program shortly. There are other organizations that we reached out to who will be joining on, or have already joined right now. And but when that time comes, and not to bore you, we will get into that conversation. Will not take much time. We'll be running into the program, the presentations shortly. In about 3 minutes or 2 minutes, we will get into that. I would just like to say thank you all for being a part of this. And in the next 1 minute thereabout, we will launch into this presentations. Do not change your dial. Lagos Talks 91.3 FM. My name is Olua Kayode, and
I am Olaoluwa Awe. Stay tuned.
That's it. Don't go anywhere.
Welcome back, Olua.
That's it. Thank you so much. And let me say that Olaoluwa Awe, she is the host of the health program on Lagos Talks, so that Healthline on Thursdays, Tuesdays, and Thursdays. So we're riding on the back of that program to show to Nigerians that we really do care and we understand what they're going through. Before you get into the introduction, what are some of the major topics you've treated in Healthline in the past, let's say, 1 month? Just so we have an idea of what complaints or Nigerians have reacted to in recent times regarding health.
We've had interesting conversations on cancer. You know, we treated it, you know, a number of times through last month, colorectal cancer. You know, we also talked about endometriosis, which is a major reproductive health issue that women face. So, you know, from core health issues like this to policy conversations around how we can improve, you know, the healthcare system in Nigeria. I mean, we have such fantastic conversations like that on Healthline, bringing, you know, experts, you know, to policy influencers so that we can have better conversations and we can build a better healthcare system. And now, before we went on that break, I know we have introduced a number of the speakers that will be engaging today. And as you mentioned, a number of them are very present with us today. But let us kickstart with the conversation on how we can reverse this trend of a brain drain, especially in the health.
All right. Well, before you get into that, it's important. We haven't done one thing, which is to read the house rules. You know, when you go for all your seminars, you get to know the house rules, where to go. One of the major things they see at seminars is that once you get there, you're told where the washroom is. Fortunately, we're all in our homes and offices, so I believe we all know where our washroom is. We don't need to be told. We don't need to be told where your washroom and all that is. But let's also remember that please, once you log on, you sign on to the program, let your phones, your volume be off. You can sign on with your video or without your video, but let your volume be off. If you want to speak as well, do ensure that we do raise our hands up. You could just hit the button there. I'm sure it's somewhere on your Zoom app. You'll be able to signify that you want to ask a question or make a comment. As much as possible, send as much comments as you want through the chat. You can send that directly to myself, Olua Kayode, or you go to Olaoluwa Awe, and we can see it and be able to respond to it as well. We'll be live on Facebook as well. So you want to share maybe more of the Facebook link so that we restrict the number of yes, just like we were saying, volume just went up now. So we refuse the distractions that we have on Zoom with the chiming in once someone logs in. Please, let's just remember, keep our mics off. And when our speakers come on, please, let's do our best to stay within the 15-20 minute gap. It's a webinar so that we can capture as much as we can. There are people listening to us from all over, which shows an indication that Nigeria should truly transform, at least gradually, after this webinar. Over to you, Olaoluwawe.
Yes, around reversing healthcare migration trend, and it is with no other person but Dr. Oshundari Tope Zenith. Welcome back, Dr. Tope Zenith. Welcome back to the health webinar.
Thank you once again, and good morning to everybody in the house and all the listeners home and abroad.
You're welcome. Now,
for the safety briefing, please remember smoking, including e-cigarettes, vaping, and use of other smoking devices, is not permitted at any time whilst on board. This includes inside the toilets, which are fitted with smoke detectors.
We're getting the feedback.
All right. Yes. Can we please mute our audio? We're getting a feedback. Okay, thank you so much. That is Nigerian Diaspora Organization UK. Thank you so much. We've acknowledged you even before you tuned in, but thank you for coming in. So back to you, Dr. Oshundara Tope Zenith.
So I understand that you have a presentation. Let's start with that. Let's hear from you. What do you think about the overall migration trend in the healthcare sector in Nigeria?
All right. Once again, I bring glad tidings and greetings from the Nigerian Association of Resident Doctors, which is one of the foremost body of doctors in the country. And we've served to, improve the health system in our society and in the country at large. The Nigerian Association of Resident Doctors, for short, is called NALD NAD, and it's an affiliate of the Nigerian Medical Association, that's NMA. Over the years, we have been battling with this issue of brain drain, just like you mentioned. And there are so many things that are accumulated into people living in droves out of the country. It is not only affecting doctors, it is affecting the health system as a whole. So you have nurses, you have pharmacists, you have physiotherapists, and other professionals within the health system that have found other places more comfortable than here in Nigeria. And if you look at what has been happening and you compare it to why people are living or those areas or those countries where they are going to, one thing is common or has been the push the drive that has been making them to fly out of the country. And one of it is the way we treat our home, which is not too good. It's suboptimal. We are not saying that the government is trying. The government is doing its own bit, our own bit, but we are still saying that they can do better. They can do more so that it will stem this tide of brain drain of people living the shores of the country to find solace, to find comfort elsewhere. Now, when I was speaking with some of my colleagues and we were having some discussion, a very good number of them told me that the first time they got to, like the person I spoke with was in the UK, and he told me that within the space of 6 months, he was able to, do things that naturally or normally is not going to be able to do if he stays back in Nigeria. I also know of someone in the UK, the US as I speak, who can afford basic life amenities, basic things. You hardly will see Nigerian doctors being able to have good access to either car loans or housing loans and all. So you have to struggle on your own before some of these basic things can be done. And it is because of this poor remuneration to health workers. That is why people have been leaving. we cannot relegate to the background the effect of better incentives to health care workers. Incentive must be adequate. Incentive must be attractive. Incentive must also be competitive. If these incentives are not attractive, nobody would want to, you will not be able to retain your own trained doctors, nurses, and other health professionals within the country. So incentive is a key factor in stemming the tide of brain drain or stemming this JAPA syndrome. We've coined a name for it, JAPA syndrome. And people, they will japa to various countries, US, UK, Australia. In fact, these North American countries like Cuba, and what have you, people are even going there. I know of people who are even going to Rwanda, African country, and it is because of our own problem. We are not treating it. In Rwanda, doctors are even paid in dollars. In Rwanda, Rwanda is just about 8 hours to Nigeria. And, they treat doctors better in all of these countries. It is also a morale booster for health workers when you treat them or you give them what is due to them. The last time salaries for doctors was reviewed in this country was about 6-7 years ago. That was 2019. And, we have a collective bargaining agreement with the Nigerian government that every 4 years, salaries should be reviewed. The incentive remuneration you are giving to doctors should be reviewed so that it can match up with the economic reality of the time. If the last time you reviewed someone's salary was in 2019 and inflation currently has almost tripled what it used to be in 2019, how do you expect that person to be able to, conveniently stay and fight or address certain issues within their system? Like I was saying, this incentive, it has to be attractive, it has to be adequate. Aside all of these things, it is also important to state that career development is also a key factor in retaining doctors or other health workers in the country. If you do not give them the technical know-how, if they are not skilled enough, it doesn't give them the competitive advantage because everybody wants to develop him or herself in his own chosen field or his or her own chosen profession. Just like you are a journalist, you go for training, you go for, a certified, where they give you a certificate after the training, either for 6 months or for 1 year or for whatever the duration may be. But do we have all of this in the country? The government is trying, like for doctors, we still have the medical residency training program where partly the government is paying for the training of doctors to become specialists in various fields. But beyond all of this, there are other better things that we can have access to. If you want to train in Nigeria as a neurosurgeon, sometimes you even have to go to very limited places in Nigeria where you can train as a neurosurgeon. If you are into cardiothoracic surgery, sometimes you have to go to places like Ghana, you have to go to South Africa. And sometimes it might be self-sponsored. I know of a doctor who went for fertility medicine and he went to India to train all on his own, account. He used his own money, sponsored himself down to India to get this training, and he came back. So if the training is not there, people will lose interest. And when they find places where they can be adequately trained, they will leave. It is part of the pull factor that is pulling people away from the country, pulling people to other places where their skills, their, the services they render is valued. So some of these things are part of what we are telling the government that they can do. And it is another opportunity, this webinar is another opportunity to make an outcry to all and sundry people who can speak to those in the corridor of power so that they can give attentive ear to some of these things we are saying. This webinar will be in vain if after the whole show, there is nothing the government, especially Lagos State government, for instance, should be able to buy into some of these things and make judicious use of the advice or of the, the summary of this webinar, so that they can improve on the quality of healthcare delivery that we have in Nigeria. It is also important to also state that you cannot have quality healthcare. Quality healthcare, the government is trying to pass the message of universal health coverage. How do you expect a doctor who is not adequately taken care of to go into underserved areas or rural areas to treat or to attend to the health challenges of people in all of these underserved areas? The government wants doctors to be available every.
Hello? Okay.
All right. I think network challenges. Maybe we should extend this webinar beyond health and look at network connectivity as well. Because that's one of the factors.
The brain in the health sector.
Yeah, because it was
in the country where it is supposed to go into all of these places.
I think we have you back now.
Yeah.
So we lost the connection for a while, but since you're back now, just allow you to wrap up in like 4 minutes, if that's okay with you. Can you hear us?
All right. Okay. Yes, I can hear you. So let me just recap some of the things I've mentioned. I've mentioned that in.
Oh, apologies. Kindly unmute yourself, Dr. Oshundara. Kindly unmute yourself.
Oh, sorry.
Okay, go ahead, please.
Can you hear me now?
Yes, we can hear you. Go ahead.
All right. So I mentioned that incentive is important in stemming the tide of brain drain in the country. Incentive is also important so that we can have skilled health workers staying within the country. And this incentive must be adequate. It must be attractive. Without making this incentive attractive, you still have people living in droves out of the country. And I also mentioned that career development is also important. We must be able to sponsor our health workers and certify them after the training. This will also help in retaining health workers within the country, and it will also give them competitive advantage. Anywhere they get to, they know they can always tender whatever certificate they have, and they can, get employment anywhere. It is also important to state that in a country like us, sometimes my prayer is always that we should not fall sick. If a doctor falls sick, do we have adequate health insurance to take care of that doctor, or to take care of a nurse, or to take care of a physiotherapist or a pharmacist when health challenges beckons? Sometimes you cannot. There are things that you cannot even avoid. I heard when Olaoluwa was mentioning
to be a richer man.
The issue of cancer.
Hold on, Dr. Tokwezenith. Let us sort out the. Please, as you join the webinar.
Yeah.
Okay, please, as you join the webinar, mute your mics. It is very, very important so that we don't keep getting the interruptions from time to time. Thank you so much. You may go ahead, Dr. Tokwezenith. Wrapping up the presentation.
Yeah. Thank you. So I was mentioning comprehensive health insurance for health workers. Of course, we know that we have the National Health Insurance Scheme, but how adequate and sufficient is this NHIS to take care of health challenges, especially when you have people with cancer, terminal diseases, or even if it is not a terminal disease, if it's something that you have to treat over time? Diabetics and hypertension, they do not have a cure, but they are diseases that you.
Hello?
All right.
Okay.
I think the network kicked in again, and we might just have to wrap it up right now. So we want to say thank you.
Thank you.
I want to say thank you to Dr. Shundara Tokwe Zenith for that presentation right there. And Dr. Shundara Tokwe Zenith, he is the
managed over,
Oh,
and you can have
okay.
hypertension. If it is now somebody who is lesser in CADA than a doctor, what do you expect will happen to the person? So my point is that comprehensive health insurance is important.
Mm-hmm. Yeah.
Okay.
Okay, we'll have to mute him
Yeah,
now
we'll
so
have to
that we
mute him,
can move on to the next speaker. I'm very sure he has spoken the mind of the resident doctors in Nigeria as the president of the Nigerian Association of Resident Doctors. But we'll take this to another level. And at this juncture, we invite Dr. Uche Ngwa, who is the associate professor at Lincoln Alexander School
As
of
part
Law
of what we can do
at
to retain
Metropolitan University in Canada. And he will be talking about, or he'll be talking about exploring financial modules for healthcare provision in Nigeria. I mean, what are the options that we have financially to upskill the healthcare sector in Nigeria? Welcome to the health webinar once again, Dr. Uche Ngwa.
Thank you very much, Laulua and Kayode. It's a pleasure to be with you this morning. I'm joining you all the way from Toronto, Canada. Good morning to our listeners listening from all over the world. So my talk today is exploring financial models for healthcare provision in Nigeria. And I would just like to pick up from where Dr. Osundara left off when he was talking about health insurance. So clearly, there is a problem about health financing in Nigeria's health system. Now, earlier, before coming on the show, I was reading somewhere about something tragic that happened in Nigeria, and it's quite trending at the moment. It's the story of a man who lost his wife, his pregnant wife, due to his inability to come up with 500,000 naira to pay for treatment. He went to a private hospital and he was turned away. He sent to a public hospital somewhere in Epe. On the way to the hospital, the wife died. And I read a follow-up account to that story that tragically, when it became time to bury the woman, he was able to raise 500,000 to bury the woman. So this is a very tragic story, but it is not unusual. That this is quite the norm in Nigeria today. And so my intervention invites us to look at this issue. There's an underlying assumption to this topic, that is exploring financial models for healthcare provision in Nigeria. The underlying assumption is that if we fix the financial bottlenecks to health service delivery, we can fundamentally fix the challenges bedeviling the provision of healthcare in Nigeria. I think this is an oversimplification of the challenges facing healthcare delivery in Nigeria. I will start off by clarifying that while our system of health financing in Nigeria is dated, as Dr. Sundara has mentioned, is dated, clunky, and incapable of delivering key objectives of the right to health, it is by no means the most significant challenge facing the provision of healthcare services in Nigeria. To my mind, the most significant challenge of healthcare provision in Nigeria is the absence of an equity-informed ideology that grounds all actions in the health sector. There are many ways where this manifests. To enumerate briefly, one, you have the paucity of government investments in critical health infrastructure to promote health service delivery. Two, you have lack of accountability of those wielding public office in implementing equity-based mandates for healthcare delivery. Three, you have the activities of private sector players in the health system whose actions are driven by profit motives other than equity considerations. So for example, the example I just gave about a man losing his wife because he was turned away. And then four, the challenge of availability, accessibility, acceptability, accessibility, and quality of health goods and services. In the examples I have enumerated here, what links them is an environment that has been created whereby equity-informed care is not a key ideology or a priority. Now, At this point, I think it's important for me to clarify what I mean by equity-informed care. Equity-informed healthcare stands for the proposition that the design and implementation of healthcare service delivery in the public and private space of Nigeria's health system needs to reduce the risk of increasing inequity as an unintended consequences. In this respect, I define health equity both as a means, that is a process, and an end, a destination. As an end, health equity is realized when individuals have the fair opportunity to reach their fullest health potential. Achieving health equity requires reducing unnecessary and avoidable differences that are unfair and unjust. Why should a senator of the Federal Republic of Nigeria have full access to coverage, including seeking medical care abroad, while the average Nigerian citizen cannot afford basic health care like maternity support or care? That's a point of inequity. And so when we talk about equity-informed care, we're talking about measures that would eliminate these occurrences. And so we should try and avoid anything that is unfair and unjust. Considering equity as a process requires working in a way that models dignity and justice when without perpetuating or recreating harm in our structures, in our strategies, and our working relationships. So here, the idea here is that even when the government is putting in place, systems and processes, we need to pay attention to how those systems and processes will actually work in practice to make sure it does not exacerbate or worsen situations of inequity. Equity in healthcare refers to the just distribution of services and benefits according to population need. As one of the 7 dimensions of quality, equity involves understanding the people being served, focusing on social determinants of health. When we talk about social determinants of health, we're talking about food, housing, clothing, the basic necessities which you need to survive. Overcoming structural barriers, that is those built-in policies and systems and services that would create barriers for this, and eliminating systemic oppression, such as tribalism or any form of discrimination, to address gaps in the experience and outcomes of the average Nigerian. Equity is demonstrated when health systems and health care is delivered in a way that supports people to achieve their health and wellness goals, regardless of social, economic, or geographic location. It does not mean that everyone must receive the exact amount of care or the same kind of care, because individuals have different expectations, histories, and needs. Equity-informed care should aim to reduce the effects of structural inequities, for example, poverty, sexism, tribalism, on people's access to the receipt of healthcare and access to the social determinants of health. It should aim to reduce the impact of multidimensional poverty on the lived experiences of Nigerians. And it should also address the frequent mismatches between the usual approaches to care and the needs of people most affected by health and social inequities. So I've spent a bit of time talking about equity-informed care, just to ground this idea, to convey this idea that a major problem we have with the health system of Nigeria is that we are lacking an ideology that centers equity as a priority. Because if we have such an ideology, it means that when the government is debating a health measure, a health policy, or a health bill, it's going to be questioning itself. How can we make sure that this measure advances the goals of equity in healthcare? If it fails that test, then it means that the measure is inadequate. So that is the reason why we need to think in terms of what is the ideology. Now, this leads me to the next part of my intervention, which is talking about the system of health financing in Nigeria. Now, having laid down this ideological foundation, I shift gears to discuss financing for healthcare provision in Nigeria. To be clear, while the government at the federal, state, and local levels are key players in the design of the healthcare policies in Nigeria, the National Health Act 2014 makes it clear that private actors in the healthcare system are equally relevant to this discussion. So when we talk about the healthcare system, we're not just talking about public healthcare systems. We're also talking about the private sector, the private health establishments. Now, I draw inspiration from WHO's universal health coverage, the WHO's universal health coverage ideation. That's the World Health Organization. That's what WHO stands for. The World Health Organization's ideation of universal health coverage to frame my contribution on financing the healthcare system of Nigeria. According to the WHO, healthcare financing is a core function of health systems that can enable progress towards universal health coverage by improving effective service coverage and financial protection. Today, millions of people do not have access to care due to costs. And I think this point is quite clear, both in the intervention of the prior speaker, Dr. Sundara, and of course, in the example I gave earlier about the unfortunate pregnant woman. Many others receive poor quality of healthcare services, even when they pay out of pocket. And that is a common experience across the country. Carefully designed and implemented health financing policy can help address these issues. For example, contracting and payment arrangements can incentivize care coordination and improve quality of care, sufficient and timely disbursement of funds to providers to ensure adequate staffing and medicine to treat patients. So when we talk about the system of health financing, if we pay attention to that system, it will address some of the concerns which Dr. Osundara mentioned in his intervention when he talked about incentivizing the medical profession so that we can have effective service delivery by our medical doctors and health workers. There is a lot of wisdom to that position because, for one, without the proper incentives in place, the situation of brain drain that was the subject of his intervention will continue unabated. But then, secondly, the absence of adequate personnel to run the health system is a major risk to the health system of Nigeria, because in the event of a crisis, you do not have the competent hands in place to help manage a public health crisis. And this is not a hypothetical situation. We saw that during the Ebola crisis, where many countries in West Africa who were hard hit by the crisis had a major problem of shortage of health workers to deal with the crisis. In fact, in some countries, people who were still in nursing school, people who were still in training, were conscripted to join the health workforce immediately because they were in dire need of health workers. Nigeria is getting dangerously close to that situation of crisis, where if we do not put in place appropriate measures to stem the tide of migration of health workers out of the country, we'll be left with a health system that has incompetent hands or not well-trained hands running it. And that is a huge risk to the Nigerian populace. And so when we're coming back to this issue of WHO's approach to health financing, it focuses on a number of core functions. One, raising revenue, that is sources of funds, including through government budgets, compulsory or voluntary prepaid insurance schemes, direct out-of-pocket payment by users, and external aid. Two, pooling of funds, the accumulation of prepaid funds on behalf of some or all of the population. And three, the purchasing of services and the payment or allocation of resources to health service providers. In addition, all countries should have policies on which services the population is entitled to. For example, it should be explicitly stated somewhere that maternal care should be a basic entitlement of every Nigerian. You do not need to have $500,000, 500,000 naira in your account to be able to access maternal care. Or that shouldn't be the case. It should be the case that maternal care should be one service that the government covers, has a fundamental entitlement of every Nigerian. In Nigeria, the National Health Act 2014 provides the framework for the regulation, development, and management of the health system, and it sets the standards for rendering health services in Nigeria. Key elements of the Act, which incorporates the idea of universal health coverage that can be the point of reference for government policy and action, include, for instance, in Part 1 of the Act, where it is clarified that both the public and private sector are part of the national health system. Part 1 also seeks to promote the spirit of cooperation and shared responsibility among all providers of health services in the Federation. It sets out the rights and obligations of healthcare providers, health workers, health establishments, and users. And it protects and promotes and seeks to fulfill the rights of every Nigerian to have access to healthcare services. Now, an interesting aspect of the National Health Act, which I want to draw attention to, is the aspect that has to do with the Basic Health Fund. The National Health Act provides for a basic healthcare fund. The Basic Healthcare Provision Fund is supposed to be that pool of funding, which is more or less a kind of a public insurance for healthcare services. The Act provides for where the contributions for this fund should come from. For example, 50% of the funding of that fund should come from the provision of, for the provision of basic minimum services to citizens, should come from the Consolidated Revenue Fund of the Federation. 1% of the Consolidated Revenue Fund of the Federation should be used, 50% should be drawn from that. So that would fund 50% of the basic healthcare fund. 20% of the fund should come from should be used to provide essential services, and 15% of the fund should be maintenance of health facilities and all of that. The basic healthcare fund should be funded by the federal government, grants from donor organizations, and funds from other sources. Now, let me compare what we have with what is going on in other countries. For example, in Canada, Canada's equivalent of the basic healthcare fund is called Medicare. Now, under the Medicare system, Medicare is a system where the state provides universal health coverage through insurance to every Canadian resident. That enables residents to be able to access certain basic services. So citizens and permanent residents are able to access certain basic services by virtue of Medicare. If you need additional protection, you can then sign up for a private health insurance coverage. Now, what is interesting about Medicare is that Medicare provides access to certain basic drugs, basic services. You can walk into a health establishment and you receive services, you are given drugs, and you pay nothing for it. That is because that funding comes from tax revenue or essentially government funding. Now, each of the provinces in Canada run their own Medicare insurance scheme. In other words, unlike in Nigeria, where the National Health Insurance Act makes it a federal, it's a federal legislation that offers coverage across the country. Imagine if we have a system where each of the 36 states in Nigeria run their own health insurance scheme, and residents in each state can be able to sign up to the health insurance scheme and be guaranteed some form of coverage. That is what the Canadian model looks like. The Nigerian model is obviously the basic healthcare insurance, basic healthcare fund, which provides for a breakdown of how the fund is to be utilized. And it says that the fund should come from the Consolidated Federation account. I would argue that there is a problem with adequate funding. if the only source of the basic healthcare fund comes from the consolidated fund. I say I just have a minute or so. Let me just quickly wrap up to say that, look, it should be the case that both the federal government and the states and the local government should contribute to the basic healthcare fund from their revenue. And that will give us more pooled funding to be able to cover basic health services so that we do not have instances where people are losing their loved ones to treatable and avoidable ailments. So I will stop my intervention here and will respond to any questions that come up. Thank you.
Thank you, Dr. Uche Ngwaba. Dr. Uche Ngwaba is our resource person from Canada, and I like how he has been able to do a comparison between the funding structure in Canada and the funding structure in Nigeria. Hopefully we'll learn one or two things, and I'm very sure we have one or two questions along that line.
Yeah, I mean, we'll get to that Q&A session shortly. And but we've had two speakers this morning, and like we do at Lagos Talks, we go to the end of the world to bring you the best. And we know there are capable Nigerians. The where we are in Nigeria today is not as a result of lack of expertise.
Okay.
It's a lack of will, probably political will or whatever, to get to where we are, because we have capable hands who can do the job and do it quite well. Now, I like you said, you've spoken about Professor. Yes, also a doctor, Dr. Uche Ngwaba, and associate professor. Let me just take you through a bit of who he is, so that Nigerians know who the person that just spoke to us is. He commenced his academic career as a research fellow at the Nigerian Institute of Advanced Legal Studies in 2010, and proceeded to Sydney in Australia to undertake his doctoral studies. His doctoral research utilized a comparative method to explore how human rights framework can strengthen Nigeria's health system to achieve universal health coverage. Before taking up his current appointment as assistant professor at the Lincoln Alexander School of Law, Toronto Metropolitan University in Canada, Dr. Ngwaba taught as a sessional lecturer in 3 Australian universities for about 5 years. That is the Macquarie University in Sydney, the Deakin University in Melbourne, and University of Western Sydney. And Dr. Ngwaba's scholarship engages multidisciplinary, comparative, and socio-legal methods in exploring complex questions affecting health governance frameworks in the global North and South. So that is who Dr. Ngwaba is. He currently leads a program of research focused on advancing a regional health governance approach in the Inter-American system. And that is who our speaker is. So once again, we say thank you so much, Dr. Ngwaba, for joining us all the way from Canada. That is around 5 a.m., 6 a.m., thereabouts in Canada right now.
That's correct.
Yeah, that's it. So for a Nigerian to wake up all the way over there just to join us, it shows how committed he is. But this is Lagos Talks 91.3 FM. Like I said, we're doing this in collaboration with our sister organization, more of our own SPV, a special purpose vehicle that we've created to drive home the change that we need. And the team lead for that special purpose vehicle will be joining us right now to give us just a little bit of talk on what it means. That is the person of, we call her Madam Amira Obiokoye. She'll be joining us right now. She is the Group Sales Director of Lagos Talks and currently the team lead for Media Impact Initiative right now. If she's ready, let's make welcome. And I'm not going to clap because my salary depends on it. I'm clapping out of love for her. So let's welcome Madam Amira Obiokoye. Welcome, ma'am. Good morning to you.
Good morning, Kayode and Olaoluwa. You guys are doing a wonderful job. Well done.
Thank you so much.
Good morning, everyone. Ladies and gentlemen, the health experts here present, both from Nigeria and in the diaspora. Thank you once again. It is my honor to speak to you today as we also would like to introduce Media Impact Alliance. Kayode has spoken so many times about Media Impact Alliance. So this is a great opportunity for us to introduce that initiative. It's a vital initiative of the Megalectrics Group. Megalectrics Group, for those who don't know, is made up of 4 brands, namely Classic FM, Beat FM, Niger FM, and Lagos Talks. Lagos Talks obviously is the baby of the family, but also is the one driving this particular initiative. Well, without further ado, let me just go on to my own talk this morning. I want to talk about the media. The media, as we all know, is an incredibly powerful tool. I say incredibly powerful tool because it shapes nations and actually influences societies. Often referred to as the fourth estate of the realm. This is because the media serves as a bridge between the government and the people, working collaboratively to foster national development. Our role in the media is not without its challenges, because we break news, we risk our lives, and we spend countless sleepless nights conducting thorough research. Tragically, many journalists and their families have faced threats, and some have lost their lives in the pursuit of truth. Despite these challenges, I must say, we remain steadfast in our demand for accountability from the government. Alas, in many parts of the world, including ours, governments often do not view the media as an ally capable of enforcing accountability and engaging with the public. Frequently, the media has access to critical information and collaborate with experts such as yourselves across various fields, equipping us with the solutions needed to address pressing issues. Yet, all too often, the relevant parties are reluctant to listen. Perhaps that's because of the stereotypes that we're facing. Some people would argue that the media are actually responsible for accelerating and also increasing the issues that the countries have in terms of the kind of sensational news that they bring to the fore. However, suffice it to say that the media landscape has actually evolved. It has changed. So those who want to know would know that actually we now have, you have solutions journalism, you have so many other pragmatic deviations of journalism as well that do not necessarily add to the issues. So I said the media landscape has evolved. We have transitioned from merely revealing issues through investigative journalism to implementing real solutions through solutions journalism. We strive to not only report, but also to influence narratives and to drive change. When our research findings are ignored, we take the initiative to establish our own SPV, which Kayode also mentioned, our own special purpose vehicle to implement impactful projects. We do not wish to be seen merely as town criers, meaning those who just inform and report the news, those who want to sensationalize the news and also educate. Instead, we aspire to lead developmental projects that directly improve the lives of Nigerians. So we want to bring best practices from other climes, and that's why we have the likes of the experts here today, so that at least now we know what is called equity-informed healthcare, which is, to my opinion, a best practice that we need to emulate. To this end, Megalectrics Media Group has established Media Impact Alliance to champion people-centered developmental projects and also advocate for meaningful progress through targeted programs. We began our project, we began our journey rather, with the Media Impact Alliance, with the Clean Lagos initiative, which we also would like to call the CLAY project, which is driven by a singular vision, which is to create a cleaner Lagos populated by healthy and prosperous individuals. Having said that, today we are proud to present our second major project, which is the Lagos Talks Health Month. As you may have seen from our lineup of speakers, our objective extends beyond mere rhetorics. We aim to learn from the successes of our fellow Nigerians abroad. We want to encourage private, people-centered investment in healthcare, want to promote subsidized healthcare led by the private sector, and ultimately enhance the well-being of Nigerians. And we believe that together we can achieve this mission. Finally, because I don't want to keep you all, it is essential to emphasize that our projects are also grounded in the social development needs of Nigerians, identified through extensive media engagements across our 4 radio stations, which I mentioned earlier: Classic FM, Beat FM, Niger FM, and of course, Lagos Talks. Thank you so much for your attention, and we look forward to collaborating with each of you to create a brighter future for our nation. Thank you. I wish you the best.
All right, Madam Amira Obi-Okoye, thank you so much for the time and the kind words there this morning. We do appreciate those words. And that is who we are. We are just a radio station, but a radio station that has gone beyond just merely reporting, which is not a bad thing. That's what a radio station does. But what we encounter every day, like some of my listeners would ask me, how do you cope daily with this tone of depressing news? Somebody is unable to access good health care. Somebody has been killed here. But we always say that we know that we have a responsibility. Almost every renowned or established country in the world once was like this, and they've all been through this, but some people stood up to pay the price and shape the nation. And that is what we are doing right here at Lagos Talks. We report, we do our findings, and we take steps like what we are doing currently.
Yeah, we also get involved.
Yes.
Because that is it. We can't just keep talking. We all have to get involved. I mean, I want to believe, Media Impact Alliance is leading, the trail on that. Lagos Talks 91.3 is leading on that. I mean, we all also have to follow in our respective institutions, in our respective spheres of influences. Are we just talking about the problem, or are we also getting involved? Are we investing? Are we putting our money where our mouth, is? I mean, that is the whole point of that. So that's what I picked from them. I mean, do go beyond listening to conversations, go beyond talking about it, get involved.
That's it. And when it comes to getting involved, I dare say that first of all, to every single person, let's just run through some of the names you have on Zoom right now. We'll come to the social media platforms later on, but the names we have on Zoom right now, that let's start with, of course, we have Tokwe Rose. Thank you for joining. Shina Olubukola Ajoke Salami and Odumbaku Kazim, Obin Obiwuru, Marcus Isa Karagama, and Kingsley Chidi Madu. We have Fidel Frederick, Eguzoro Onyedikachi, Dr. Guaba, definitely, Dr. Oshundara Tokwe Zenith, Dr. Omoni Binu Oji, and of course Amira Obi-Okoye. And of course, there's Ololuwa who's seated right here in front of me.
Of course, I'm here too.
Yeah, that's it. So I want to celebrate all of you, and this is just the beginning of many more great things to come, because we believe that with this, we will identify some of the challenges we have in Nigeria, and with this as well, we will be able to take steps to influence, to transform, steps that are needed to cause a change. Now, there are so many things we pick from what Dr. Ungwamba has said, and of course what Dr. Oshundara also said. And a lot of these things, we need to begin to work at it to influence Nigeria. Now, as a station and as Media Impact Initiative Alliance, this is just the beginning. Many more things will be done along the health line. Many more projects will be done because we believe that it's not just about setting up institutions or health facilities. It's also about even rallying people around. We have a lot of Nigerians abroad that we believe that, okay, as experts in their rights in the healthcare, if we're able to gather them and say, okay, this year or over the next 2 years, we want to work with this particular hospital, we champion it across Nigeria. Let's begin to optimize and get our hospitals to perform a lot better. So this is just one of many more things that we will be getting into shortly. So
yeah, speaking of many more things, I mean, we still have two amazing conversations or presentations to be had before we get into the Q&A session. Yes, I'm talking about the third presentation from Professor Abimbola Akintade, and he is the Dean of East Carolina University College of Nursing. He will be discussing government and private sector collaboration in providing quality care. After that as well, we'll have Pastor Peters Omaragmo, who will be our final speaker today. He'll be doing the final presentation before we get into the Q&A. Pastor Peters Osawaru Omaragmo is the Executive President of Nurses Across International. He'll also be talking about the plight and right of a Nigerian nurse. I believe Professor Abimbola Akintade
he should be joining us. I think he signed up there, so he will be joining us shortly, and we'll also have that of Pastor Peters Omaragmo. The profile of some of these persons later on.
Yes, before we do that, I want to implore us again, if you have questions and contributions, you can begin to drop them on our Facebook Live, or also you can reach out to us via our studio WhatsApp platform, which is 0809-234-5913. Again, let us this to pull from different parts of the world.
And of course, in addition to that, we're also live on Facebook at Lagos Talks 913. We are live on Facebook, Lagos Talks 913, where we are, projecting all the conversation right here. But in addition to the WhatsApp messages, you could also shoot in a WhatsApp, maybe a voice note, so that we could play that out, or even if you can risk a WhatsApp call. We'll see if we can patch you on, but it's all about getting Nigerians involved. It's all about getting Nigerians to be a part of this conversation. So in a short while, we'll get into the presentation. Most likely, we'll reverse the trend this morning, and we will bring you the presentation of Pastor Peters Omaragmo before we go to the presentation of Professor Abimbola Akintade. So that might be the flip, the switch that will happen in a short while. But I think it says we're a radio station and we're used to taking breaks. It's only normal that if we take a short break, just to let our speakers just relax a bit, and our listeners just get ready. I'm sure there are one or two persons that want to stand up to pick up one or two things. Let's just sort that out.
Just gather your questions ready for us. Because when we come back from this break, it'll be great conversations back to back. Back to back, that's it. So do not change your dial. Lagos Talks 91.3 FM. Definitely will be right back. All right, so welcome back to the studio right here at Lagos Talks 91.3 FM. And like we said, we might flip the coin a bit. We might just, which is what I believe we'll be doing now. We'll be bringing you the presentation of Pastor Omaragmo. He is the one whose clip will be, whose presentation will be done right about now. And but before we get into that, before we get into that, if you're just tuning in, this is a special health webinar on Lagos Talks 91.3. This is how we Health Month, and it says back to back from our special guests from Nigeria, from Canada, and all around the world. We've had the president of Nigerian Association of Resident Doctors, Dr. Oshundara Tope Zenith, and we've also spoken with Dr. Uche Ngwaba, who is also a top shot in the health sector there in Canada, in Nigeria. We now move on, we take it a step further, as always, with the presentation from Dr. Omaragmo, and that is what we'll get into right now. But just before that, I want to tell you a bit about Pastor Omaragmo. We need to have an understanding of the person we are speaking about. Let me just open that up here. Shut down a bit. We know he's the executive president of Nurses Across Borders International. That's Pastor Peters Osawaru Omoragbo, and you'll be talking about the plight and rights of a Nigerian nurse. But of course, we need to understand who he is. I mean, why is he in the best position to give this presentation at this point in time? I'm interested in listening to that, because I feel like a number of times we misunderstand Nigerian nurses. We don't even accord them as much respect we accord the doctors. I mean, the conversation is that the treatment we give to doctors in terms of their pay, their welfare, the respect, their security is not even enough. You know, the career progression they get to enjoy doing their profession here in Nigeria is not even enough. So not to speak of the Nigerian nurses. And we know that nurses globally are hot cake. I mean, they are just really well sought after all around the world. So while we talk about the brain drain with doctors, do we even consider the brain drain with nurses? We have people now who go do short courses in nursing just so that they can travel abroad. In fact, being a nurse now is like something everyone wants to do now. So that, in fact, there are people who want to get married to nurses just because so that they can get their papers. But the ones, yes,
but not to serve the people.
But not to serve the people. And we are not even interested in keeping them within the country. It is believed that some of them, their fundamental human rights, their professional rights are infringed upon from time to time. And that is one thing I'm hoping that Pastor Peter Omoragbo will help us understand in detail today on the health webinar. And if you're a nurse, you're listening, you know a nurse, you know, this is the time to also ask questions. I hope we're getting our questions ready, because I mean, once we're done with Dr. Pastor Peter Omoragbo's presentation, and we also take the next presentation there, we will be getting into question and answer session. I mean, I always look forward to that particular session. Get your questions ready. Is it about the sector as a whole? Is it about how Nigerian doctors or health workers conduct and compose themselves? If you're also a healthcare professional, are there professional questions? I mean, the people we have speaking today, they've had years of experience in this sector. They've had the opportunity to engage with the government at different points.
Let's take a listen to comment from Pastor Omoragbo as he joined as well. We're playing a clip of his right now. I hope you can hear that a bit clearer right now. This is Lagos Talks Health Webinar happening on the 7th day of April, right here in the beautiful city of Lagos, and International, should I say, World Health Day.
Good afternoon, ladies and gentlemen, and good afternoon, my fellow co-contributors to this panel today. First, my name is Pastor Peter Omoragbo. I am the Executive President of Nurses Across the Borders. I'm the President of the Diaspora Nurses Association of Nigeria, and Secretary of Nigeria's Diaspora Organization, United Kingdom Chapter. It's my pleasure to be here with you, and may I seize this opportunity to thank the organizers of this event, that is Lagos Talks, that is 1.3 FM. Thank you for putting this discussion together, and the team is apt at this 2025 World Day celebration. The topic that I've been asked to speak on today is the plight and rights of Nigerian nurses, a comparative analysis with global standards. This is a paper that I'm presenting at the 2025 World Health Day public webinar organized by Lagos Talks 91.3 FM on today, Monday, April 7th, 2025. The global nursing workforce is the backbone of any healthcare system. We all agree that nurses form the largest single professional group in any health sector. But yet, nurses in low income and middle income countries, particularly in Nigeria, face systemic inequities that undermine their professional rights, dignity, and capacity to deliver quality care. As the WHO emphasizes, achieving universal health coverage by 2030 hinges on addressing workforce disparities and ensuring nurses operate in environments aligned with international standards. Nigeria, Africa's most populous nation, exemplifies the paradox of a country rich in human capital yet crippled by healthcare workforce exploitation, migration crisis, and institutional neglect. This paper provides a comprehensive analysis of the plight of Nigerian nurses, contrasting their working conditions, migration challenges, and policy frameworks with global benchmarks. By examining systemic failures and proposing actionable reforms, this paper advocates for equity-driven policies to uphold nurses' rights and strengthen Nigerian healthcare system. I'll be looking at this paper in 6 different sub-themes. The first sub-theme is the plight of Nigerian nurses in multifaceted crisis. And this I'll look under number 1, poor working conditions and remuneration. Nigerian nurses labor in environments marked by chronic understaffing, inadequate resources, and salaries that fail to meet basic living standards. For instance, a nurse in Lagos State University Hospital often manages 30 to 40 patients per shift, which far exceeds the WHO recommended nurse-to-patient ratio of 1:6 in acute care settings. Every entry-level nurses earn between $75,000 to $100,000 monthly, which is equivalent to about $32.65 to $65 a month. While senior nurses with over a decade of experience rarely earn above $200,000. That is about $124. Comparatively, nurses in the United Kingdom, NHS service, that is the National Health Service, earn between $28,000 to $42,000 per annum, with guaranteed overtime pay and pension benefits. The economic disparity exacerbated by Nigeria's inflation rate, which reached 33% in 2024, eroded purchasing powers. Nurses often work multiple jobs or rely on informal under-the-table payments from patients to survive in what they call private practice. In rural areas like Borno State, hazards, including exposure to infectious diseases like Lassa fever and inadequate personal protective equipment. A 2023 survey by the National Association of Nigerian Nurses and Midwives (NAM) revealed that 78% of nurses lack access to functional oxygen tanks and 62% use gloves due to shortages. For example, in 2022, a nurse at Abuja General Hospital died of Lassa fever after treating a patient without PPE. Our family received no compensation, reflecting systemic neglect of occupational safety. Another problem under the multifaceted crisis is systemic barriers to professional development. Nigerian nursing education system is outdated and underfunded. The Nursing and Midwifery Council of Nigeria mandates a 7-year training pathway, 5 years of academic study, 1 year of internship, and 1 year of compulsory national service. However, nursing schools lack simulation labs, e-learning resources, and opportunities for specialization. For example, Nigeria has only 12 accredited institutions offering postgraduate nursing programs, compared to over 200 in South Africa. The Nursing and Midwifery Council recent policy further stifled growth. The policy that was made in 2024, where it imposed a mandatory 2-year domestic service requirement post-qualification and a 6-month verification process for nurses seeking overseas employment. Nurses argue these rules are exploitative, forcing them into underpaid roles, while high-income countries like the United Kingdom actively recruit them. Comparatively, Ghana's Nursing and Midwifery Council requires only 3 years of domestic services and collaborate with the diaspora networks for skill exchange. Another example was a nurse in Enugu reporting waiting 8 months for Nursing and Midwifery Council to verify her credentials for UK employment, during which she worked underpaid at the local clinic due to unemployment. There are more qualified nurses in Nigeria today, more than qualified nurses. And these issues are not helped by doctors who own private clinics. Instead of employing qualified nurses, all they do is to choose to train people who are not too educated on how to give injections, and they teach them the basic rudiments of delivery, and then they put them to uniform. At the whole of Nigeria today, you have a lot of people wearing the white and the nurses cap, and they are looked at as nurses. The regulation of these private clinics and hospitals are not done because you have doctors who are commissioners of health, doctors and ministers of health, and so they own these private hospitals. So they constitute the greatest barrier in proper monitoring of these hospitals. Another issue has to do with migration, exploitation, and ethical concerns. Over 42,000 Nigerian nurses migrated abroad between 2021 to 2023, driven by economic hardship and lack of career progression. However, their journeys are fraught with exploitation by recruitment agencies that charge them exorbitant fees for just documentation verification and credential discrimination. Nurses in the UK, Nigerian nurses in the UK face prolonged registration process and are often placed in lower pay bands than British trained nurses, which is correct because number one, we are meant to do a lot of, you are meant to do IELTS exam, but remember, our training from primary school to university is done by English language. Our practice is by English language. And so how we do our examination with English language. And then we expect us to do English language tests. In most cases, they continually fail you. For every exam you pay, for application fee you pay, and once the process is not completed, you have to start afresh. And within a period of 2 years, they expect to complete the process. And in most cases, most nurses takes them about 6 to 7, 8 years before they can finally be accredited by the NMC. The NMC is exploiting them by making a lot of money out of them. The recruitment agency that will bring them are exploiting them with no job, and they're giving them lower cadre jobs. Now, exam fraud allegation. In 2023, the UK Nursing and Midwifery Council barred 609 Nigerian nurses applicants after allegedly discovering proxy text stickers at an Ibadan exam center. In fact, this issue up until tomorrow, made a lot of publicity. In fact, Nigeria, it was like, oh, Nigeria is known for nothing but fraud. But what is very interesting is that these were mere allegations. The Nursing and Midwifery Council, using the perceived view that helped them to organize the computer-based test, alleged that the majority of the nurses did their exam in a very fast time, and then they started querying, and then they looked at about 1,000 plus nurses. I am not in support of any nurse committing any fraud, but the issue is that there is nowhere in the world whereby an exam is going to take 1 hour, you pass it in 20 minutes, it constitutes a crime. As long as there was no evidence of you cheating or fraud, let it change your exam. They said they were proxy text writers, meaning people wrote exams for these nurses. The question is, present these proxy text writers. Up until date, the Nursing and Midwifery Council cannot produce one single proxy text writer that must have written an exam for any of these nurses. So it was as a result of that that we became interested that my organization, Nurses Across the Borders, have to organize for a law firm on behalf of about 50 of these nurses to challenge the Nursing and Midwifery Council, asking them to prove, to the strictest proof, evidence to demonstrate that this nurses committed fraud. The case is still on, and I can let you know that yes, in fact, it was highly publicized by the Nursing Times, because it's not enough for you to allege. The onus is on those who are alleged to prove. And then there was this deliberate profiling of Nigeria. And as it is, the North African Council is stalled because, number one, they are finding it very difficult to prove the allegation. And what they are doing is delaying the trial of these nurses. These nurses, because they could not complete the process of their registration with the NMC, because most of them came through sponsorship, and they were given 8 months to pass their house. The North African Council, by the delay, sacked this nurse. Because they are sacked of sponsorship, it's plain upon the fact that majority of them will be deported, so that they will be spared the opportunity of trying to prove or go through a legal case. But that is not going to happen, because so far so good, we are taking them up on this. So there was also the case of a Nigerian nurse in Manchester who reported early 22,000 per annum, 6,000 less than a British trained nurse with the same qualification. Now, another issue we have to look into is the WHO guidelines and best practices. The WHO strategic directions for nursing and midwifery 2021 to 25 outline 4 pillars of workforce strengthening. One of them is education. That means you have to align your curriculum with global competencies, e.g., in digital health, disaster response. And in fact, nurses across the borders were also very involved with the training of the capacity of nurses in trying to mitigate and adapt against climate change, disaster risk reduction. So we told that employment, that is the WHO specify that the workforce, they must ensure safe staffing ratios and competitive wages. Remember, I said earlier, the ratio of the nurse-patient ratio in Nigeria is such that yes, it far outweighs the 1:6 ratio, one nurse to 6 patients. Leadership. Nurses are not integrated into policy-making rules. That's why today, both at the state, local, and the federal, the nurses are not even made. In fact, you don't even have a director of nursing. That is headed by a nurse in the Federal Ministry of Health. All you have is a division of nursing under a directorate headed by a medical doctor. And yet, we consider the largest. So all these are deliberate policies that are aimed to frustrate the growth and development of nurses. Whereas here in the United Kingdom, where we are practicing, you have nurses as medical directors. The secretary for health in the United Kingdom are career civil servants. They are not doctors. And so that is why you now have the democratic structure within the health care here. So there is no one single professional group within the health sector that overrides the others. Everyone is equal because we are professionals. Now, in countries like Ghana, the Ghana Ministry of Health is partnering with the Ghanaian Diaspora Organization to help train and retrain their nurses. And they offer tuition reimbursement for nurses who commit to rural postings. But even in Nigeria, nurses are made to pay for their training. And then after paying for their training, they want nurses now to be posted to rural areas at their own expense. No incentive, nothing. When we train in Nigeria in our days, we were placed on level 4. We were being paid salary. So a lot of us were excited about being nurses because we were getting paid. But now nurses have to pay through their nurses. And after payment, they don't even get a job they pay for. Even the few ones that get government job, there's not much incentive with no adequate facilities to work with. Now, in the United Kingdom, relief. The United Kingdom relies on Nigerian nurses to fill staffing gaps, with about 10,630 Nigerian trained nurses registered in the UK as of 2023. Because in the United Kingdom, there must be equal number of nurses to the available admitted patients. Because when there's a deficit, within the NHS, then the NHS goes out and asks for agency to bring qualified nurses because the ratio must be met. If not, the NHS will be made to pay for a lot of damages from understaffing any ward. That is a country that takes the health of the citizens seriously. However, the UK's code of practice for international recruitment allowing private agencies to exploit Nigerian nurses. Because nurses come, they engage them, but there's no regulation to monitor how they come and how they work with, as long as they help to fill the gap. Now, let's also look at regional comparison. Ghana and Kenya. Ghana has a streamlined credential verification for 3 months. Now, nurses, there is an established nurse allowance offering 30% salary bonus for rural service. That is for Ghana, just to an incentive for nurses who want to work. No. Whereas in Kenya signed a bilateral agreement with Saudi Arabia and Germany to export nurses while expanding domestic training capacity. What this means is that the Saudi Arabia and the Germany, they provide funding for the training of nurses in Kenya. And then the Kenyan government now allow their nurses under what it means, export them out because it's a give and take. There is a reciprocity. So why can't Nigeria do that? You have more than 40,000 Nigerian trained nurses within the last 4 years that have gone out of the country. But that's a loss of the country's healthcare delivery. But financially, the government is not doing anything to streamline this process like what they're doing in Ghana or what they're doing in Kenya. Now, but noise across the borders has just entered into an MOU with what the World Continuing Education Alliance data flow with the Nigerians in Diaspora Organization Europe. What this collaboration entails is that data flow is an international verification agency. What they do, they have to verify medical practitioners' certificates, and then they also have to verify where they're going to work. And so once verified, it is internationally accepted anyway. They are doing this for Saudi Arabia, they are doing this in Kenya, they are doing this for the Filipino nurses, they are doing it for other countries. So we've also entered into an MOU with them, and then we brought in the Nigerians in Diaspora Organization Europe, which is the central body coordinating the professionals, Nigerian professionals in Europe. This project is going to be launched later this year, around July, during the 2025 Diaspora Day celebration. So that with this collaboration, we want to involve the Federal Ministry of Health, we want to involve the Federal Ministry of Foreign Affairs, the Nigerian Diaspora Commission, so that any Nigerian nurse or midwife or doctors want to go out, their verification, their documentation and verification is not streamlined by data flow. Wherever they are going, they do the background check, and so they will be able to monitor them. Apart from them going out to Nigeria, they also assist them in coming back. Those who want to come to Nigeria to work, they will be able to verify them and also come to Nigeria. So it's a two-way benefit for both the nation and the professionals. The fourth point has to do with the rights of Nigerian nurses, the legal and ethical dimensions. Now, Nigerian nurses deserve right to fair labor practices. This is in line with the International Labour Organization Convention 149, which guarantees nurses fair wages, safe workplace, and collective bargaining rights. However, Nigerian nurses face union suppression. Now leaders are routinely harassed. Majority of the private hospitals, big private hospitals, don't even allow the nurses to organize themselves into union. And whereas they are using them more and underpay them. Now, there's nurses in Nigeria suffer unpaid salaries. States like Kogi, some time ago, owed nurses 18 months of wages, violating the Nigerian Labour Act of 2004. In 2023, nurses in Ondo stayed a sit-in after the government diverted their salaries to fund political campaigns. The is a country, this is a nation that should make health its priority. Now, there's also the right to freedom of movement. Article 13 of the Universal Declaration of Human Rights guarantees freedom of movement. The National Assembly Council 2-year service rule that was made about 2 years ago, anyway, that has been cancelled, almost frustrated this freedom of movement. But that rule has been jettisoned after both parties, because the nurses took the nursing council to court, but it's still out of court, and that law is no more in operation. Now, the right to professional dignity. Nigerian nurses enjoy systemic disrespect, including gender discrimination. 87% of Nigerian nurses are women, yet they are excluded from leadership roles. Only 2% of hospital CEOs are nurses. Nurses are made to be subordinate to doctors, whereas they're supposed to be professionals working side by side, parallel. The INT, the Industrial Relation Panel Award of 1980, that recognized nursing as a profession, sui generis, directing the federal ministries of health and state ministries to establish directorate of nursing from the state to the federal. All the states have established it. The federal ministry have refused to establish a standard directorate of nursing services. All they still want to continue to keep nurses to be subservient to the medical doctors. Which should it be? Now, what is the global contrast? In the UK, nurses lead independent clinic and prescribe medications under the NMC standard of proficiency. Nurses are medical directors in large private hospitals. Like I said earlier, the Secretary of State in the United Kingdom is a civil servant. What are my recommendations as I close? Number one, there is a need to align it with the WHO standards. That means, in terms of education, the Nigerian Nursing and Midwifery Council and the Federal Ministry of Health, with organizations like Nurses Across the Borders and the Diaspora Nurses Association of Nigeria, we should partner with institutions like John Hopkins to establish simulation labs and e-learning platform. There's a need for wage reforms. Benchmark salaries to WHO living wage guidelines, e.g., at least the entry point for any professional nurse should be not less than 500,000 naira per month. Now, ethical recruitment. There's a need to adopt the WHO Global Code of Practice by requiring destination countries to fund Nigerian training programs. The British system has benefited more from the Nigerian trained nurses. 1 in every 4 black nurses in the United Kingdom is in Nigeria. There are 3 leading countries. You have Filipinos, India. Nigeria will constitute the 3rd largest professional nurses in the United Kingdom. So there's time for us to fashion a method whereby Britain will have to be funding the training at the hospitals of Nigeria, in Nigeria, so where these nurses are trained from. Now, there's also the need to strengthen governance and advocacy. The NMC the governance has to be strengthened, they need independence in their activities. It's a show whereby they are not allowed that independence. They have to go to the Federal Ministry of Health to get permission for anything. This is a professional body. The NMC UK is set up by statute, and they do whatever they want to do, regulates the practice and the training of nurses. They don't need to go and be taking permission from the Secretary of Health for anything. So they have that freedom, they have that independence to function, because as a professional group rather. So that has to change. That's right, engagement. Now there's a need to create a Nigerian Nurses Diaspora Commission to facilitate knowledge exchange and investment. There is a nurse technical committee made up of leaders of diaspora nurse organizations set up in 2012 by the Federal Ministry of Health. In fact, I was a member of that committee when it was set up in 2012. We have to develop the document to regularize medical missions in Nigeria and all that. After about 2 or 3 years, as soon as the minister that was there was changed, that body remained moribund. Because that would have been a very good forum for us to exchange ideas and see how we can also bring our expertise from the diaspora to supporting the growth. But beyond that, we still come back home under the Nigerian Security Organization for Homeland Development every year to provide the little we can provide, support nurses, provide training for both doctors and nurses, and then even help in building and renovating primary health care centers. So now there is a need for global solidarity and accountability. High income countries should allocate at least 0.1% of health budgets to low and middle income countries for nurse training. Civil society support campaign like the Diaspora Nurse Association of Nigeria that I'm president, the Nurses Across the Borders Humanitarian Initiative, the Nigerians in Diaspora Organization, NIDO Europe, and the NIDO chapters all over Europe can also provide a support base for improving the welfare and the condition of nurses. In concluding, the plight of Nigerian nurses underscores a global health inequity crisis. While Nigeria grapples with brain drain and exploitation, high-income countries benefit from Nigerian expertise without reciprocal investment. Addressing this requires dismantling exploitative policies, aligning Nigerian standards with WHO guidelines, and fostering international solidarity. As the WHO asserts, no health without a workforce. In truth, demanding urgent, collaborative action for both nurses' rights and rebuild Nigeria's healthcare system. Thank you very much, and I will conclude my lecture. God bless you.
Wow. Thank you so much, Pastor Omoragon, for your words there. I believe that we all heard what he said, and I don't know how that sits with you, Olaoluwa, hearing all the statistics that he reeled out, the conversation he had about saying about 40,000 nurses have left Nigeria in the last, did he say 10 years or 4 years? Saying that Nigeria makes up about 1/3 of, is the third largest group of foreign nurses in the UK.
Yes, one in every four black nurses in the UK is a Nigerian.
Yes.
And he made some important points there. He did say, I heard him say that the minimum wage for Nigerian nurses should be nothing less than 500,000 naira.
Yes, yes.
And I agree. 500,000 naira isn't much.
Today it isn't.
In this economy. If you're earning 500,000 naira per month, I mean,
you're just getting by.
You're just getting by.
You're just having
an average Nigerian nurse should be able to get by.
But while you're talking about the average Nigerian nurse and what they deserve, did you hear the figure he reeled out? It says in the UK or in Europe, it says an average nurse earns between £28,000 pounds or dollars to $42,000. But in Nigeria, entry-level nurses get about between 75 to 100,000, which is approximately $32 per month. And if you've been there, well, 200,000 naira, which is approximately $145 per month. Compare that. 145, let's even say times 12, that's about, let's say 10 is 140. Yeah, so let's say around 160,000. 1,600.
My math is bad.
Yeah, your math is bad. $1,600 per year. Can you compare 1,000? Oh, let's even at most $2,000, less than $2,000 per year. Okay. Can you compare that with $28,000 per year? Who would not jackpot for such a reason?
And from what I heard, in certain institutions outside of the country, nurses are even paid more than doctors. But if we compare that to what we have here, I mean, and I wonder, why don't our nurses even get as much attention as the doctors? Because doctors, they go on strike from time to time. At least we know they have a problem, you know, and we know, I mean, there's always this back and forth from time to time. But
we hardly get
Nigerian nurses are just there earning,
midwives,
earning nothing. And it looks as if, I mean, it looks as if they're okay. I mean, they just channel their energy into leaving the country.
And so when you now look at that, and this is not to say the doctors are not underpaid. No, it's far from it.
It is.
But we're looking at nurses right now. That
even
the
worse.
doctors, it's worse. Because now the doctors, they'll go out there, react. From time to time, they get this increment in salaries. And, you know, at times it is also cascaded to the nurses, but still little. Now, you now look at the doctor who has complained. When you get to a hospital, the first interaction you get is with a nurse. Takes your vital stats, attends to you, does a lot of things with you. You interact a lot more with nurses than the doctor, because even after you meet the doctor, if you have to go for injection, you go back to the nurse. A lot of the things you do, you go back to the nurse.
Doctors can't even do their jobs without the nurses.
No, and neither can the nurses do their jobs without the doctors, because they're supposed to complement each other. And that's what Pastor Moragban was saying, that no one is subservient. We are all equal. You do your job this way, and I do my job. I remember some time ago, I took my child to a hospital in Ghana, and when we got to the hospital, the doctor, a young doctor, gave a prescription. And when the nurse saw it, he said, "Who gave you this prescription?" We said, "Oh, it was that doctor." He just laughed, looked at the colleague and said, "No, he's wrong. Take it back to him." I mean, this is something she's been doing for like 20 years or so. You're fresh out of school. You're about to make mistakes. So, I mean, they both contribute to quality health. And I haven't said this. Maybe we should go to Dr. Uche Ngwaba, to maybe get an understanding of what happens in his space, because I know he has to go right now. So it's just important we engage him a short while before he leaves us and takes leave of us. Dr. Uche Ngwaba, if you're there, I just want to engage you a bit. Let's understand your space. What is the relationship between doctors and nurses?
Okay, thank you. Thank you very much. Can you hear me?
Yeah, we can hear you.
Okay. Now, the doctors and nurses, they're part of the health system. They each play very important roles within the context of health service delivery and healthcare provision. And so I have listened, of course, with interest to the interventions by the last panelists. And I must quite say that I agree with everything he has said in terms of paying attention to the healthcare workforce. There are obviously synergies and, of course, connections between all of the conversations all of the presentations that have been made. Listening in the morning to Dr. Sundara, and now listening to the last Pastor Amor Robert, also the last speaker. So now we can see that the health system itself depends on the critical support of doctors, but also the technical staff. For example, the lab technicians and other important support staff in the health system. Now, if we want to reform the health system, we need to pay attention to the conditions of service of doctors and the conditions of service of nurses. There's no way you can achieve the kind of outcomes we are talking about in terms of equity-centered care if the very workforce that is responsible for driving equity-centered care don't feel that they are getting equity in terms of what is deserving to them. A lot of the sharp practices we see in the system, a lot of the waste, a lot of the corruption we see in the system stems from the fact that there has been a long period of neglect. It's interesting to note that countries like Saudi Arabia and many other countries, even within Africa, had their health systems built by Nigerian doctors and Nigerian nurses.
Wow.
You would be surprised to note that there was a time when the royal family from Saudi Arabia comes to Nigeria for healthcare, to receive healthcare services. That is where we have fallen from. And so the question then becomes, why have things become this bad? Why have things, deteriorated to this extent? So I think it's a time for us to sort of reflect soberly on what is happening in the system, because I think that policymakers have for too long neglected the health system to the point where now everywhere else is better than Nigeria. That is troubling. It's deeply troubling. And so there is no greater point that can be made than to say that, look, you need to invest in the health sector. I can assure you that in the developed world, over 50% of their GDP goes into the health system. In Australia, that is the case. In Australia, because I lived in Australia for about 8 years, the easiest job you can get is a job in the health sector. That's the biggest, yes, easiest job you can get is a job in the health sector. The most paying jobs for new immigrants is support work. That is a sector that supports, equity-oriented services, including caring for vulnerable people, caring for old folks, and so on and so forth. A lot of money is invested in that sector. Australia has what they call NDIS, National Disability Insurance Scheme, to fund that sector. Across other aspects of the value chain of health service delivery, there's enormous funding funneled into the system. Why do we have something different in Nigeria? How much of our budget goes into health? How much is being invested by the states? What about the local government areas? How much of their budget goes into funding the health service delivery? Because primary healthcare is under the responsibility of local governments. Yet they are the least funded tier of government in the country. So if the least funded tier of government is responsible for the most important level of care, primary healthcare, that tells you where our priorities lie. We are not really serious about this. So I think all of the interventions all speak to one thing. There is a significant systemic challenge in the health system of Nigeria that requires a very, a concrete and radical, action by all players. We cannot just say it's the role of the government alone. The government, the citizenry, the private sector, businesses. Why should the companies that are doing business in Nigeria, why are they not investing in the health system? Why are they not providing full coverage for their staff? Because if every company is providing private insurance coverage for their staff, that is one less person who has to be denied access to care because they don't have money to pay for basic health services. So let me leave it at this point. I hope I've been able to sort of shed a bit more light to the conversation.
Yes.
Sure have.
I have one more question to go for you, Dr.
Uche.
Yes. And you've made some fantastic points during your presentation, I must say, talking about equity when it comes to healthcare provision. And you talked about financing. And the interesting thing about your presentation is that you were able to look at it from the angle of the recipient of healthcare, how they can afford, this healthcare. So what would you say is the thing that needs to be done to make healthcare investment attractive to private investors in Nigeria? Because investors, they want to make their money and all. I know some people are going into it, but we need more, and we need more collaboration with the public funds that we have available. But how can we get more private investors into this?
Okay, thank you very much. Now, let me begin by saying that everywhere in the world, there is nowhere in the world where the business of health is left to the private sector alone. The biggest, and I agree with you that health is big business, but the biggest driver of the business of health is actually the governments. Now, the government has to make the private health, the healthcare space very attractive for investments. Nigeria has a problem of overregulation. There is just too much regulatory bottlenecks all over the place that sometimes these regulations don't make sense in terms of what are they trying to achieve. One of the points I made in my presentation was that in every set of policy ideation in the government, there has to be attention to the equity impacts. And that's the point I was trying to make about equity-informed healthcare. Now, if we think in terms of how does this advance the goals of equity, we don't sort of break it down to what does equity allow us to achieve in the health system. What equity will allow us to achieve in the health system is it will allow us to pay attention to what I call triple AQ: availability, accessibility, acceptability, and quality of health goods and services. And so the government will be thinking, how can we attract private investors to come and invest, say, for example, in cancer care in the country? How do we open up the space so that, and I can assure you that there are lots of, even in the diaspora, there are people who are in the diaspora who have this funding and who have the ability to be able to sort of build a world-class cancer hospital in Nigeria. But then when they think about all of the regulatory hoops they have to go across, the risk, the business risk of doing business in Nigeria, just the entire chaos they will have to go through, they just stop it. They say, you know what, let me just look for some sort of equity or some stock and invest my money there. So when you think very critically about this, I think that to achieve these objectives, government needs to take a driving seat. There is a point that comes across in my presentation, which is sort of, not so apparent, which is this point that health as a right is not an entitlement of Nigerians. Nigerians are not entitled to the right to health. This is despite yes, Nigerians are not entitled to the right to health. Let me tell you why.
That mean, okay.
Even though the Basic Healthcare Act says advance the right to health, there is a provision in the Constitution that says that the right to health is not justiciable. Okay, it's because the right to health is under Part 2 of the Constitution, which is the fundamental objective and directive principle of state policy. Part 2 of the Constitution is not justiciable, meaning you can't go to court and enforce it, right? Nigeria has ratified the African Charter on Human and People's Rights, which guarantees the right to health. But there is a case, I researched this point during my PhD. There is a case where the Supreme Court of Nigeria says that the African Charter cannot make justiciable what the Nigerian Constitution says is not justiciable. So what does that tell you? It said that there is an attitude and a behavior that suggests that Nigerians are not entitled to the right to health. That is why an average Nigerian does not believe that the government owes him a right to health. How many times have you heard of somebody suing the government say, oh, my right to health is not being fulfilled. I'm suing the government for violation of my rights. Have you seen any action like that? No, you can't. You rather see actions about fundamental rights. You say, oh, the police has violated my fundamental rights, and they'll clearly take the police to court. But there's no one who has taken the government to court for violation of the right to health. And so when the governor builds a primary healthcare center and does not stock it with medicine or stocks it with substandard goods and services, he comes on radio or on the newspapers and says, I have done something, and he wants people to applaud him. Meanwhile, what you're doing is your fundamental obligation to the states. You have not done anything to be proud of. There's nothing to celebrate there. But then we see politicians celebrating little things to do in healthcare, and they want us to clap for them when you're just doing your fundamental role. So all of this leads to my position that Nigerians don't have the right to health, because even Nigerians themselves do not believe they have the right to health.
But globally, the standard is that the citizens have a right to health.
Oh, absolutely. Absolutely. The International Covenant on Economic, Social, and Cultural Rights is an international treaty which Nigeria has ratified, which obligates states to provide for their citizens the right to health. Article 12 of the ICC, the International Covenant on Economic, Social, and Cultural Rights, provides for that obligation. Nigeria is bound by that obligation because Nigeria has ratified that treaty. So when I say Nigerians do not have the right to health, I'm not saying that there are no laws or obligations or international commitments that make the government obligated to secure the right to health for Nigerians. What I'm saying is that the practice is that there is an attitude and a behavior that suggests that Nigerians are not entitled to the right to health. And it is up to Nigerians to begin to hold their elected officials accountable, to begin to hold people who hold public office accountable. It is quite ridiculous what is happening in the country, where people who hold public office, they are entitled to the highest level of care. The other day, I was listening to a former senator talk about one of the wrong things that the current Senate president did to him. It was like he went for he was entitled to $14,000 for medical care abroad or something like that, and he was denied. And I was listening to that in amazement. I say, how ridiculous! This same country we are in, somebody is complaining that he was entitled to $14,000.
One person.
I think it's Senator. I forget his name now, but it's a young, quite. Yes, that's correct. That's correct. I was listening to him and I was shocked that this man should not be saying this in public, because the people who are listening to him have never seen $1,000. They can't even afford $1,000 US, and then you are saying you are entitled, and that's public fund, by the way. So it just gives you an idea of how much elected officials are entitled to in terms of healthcare access. They're entitled to go abroad. Why should they go abroad? Why should they use public money to go abroad to go and receive treatment? Why don't you invest in the healthcare system in Nigeria and go to local healthcare treatment centers in Nigeria to get treatments? So I think it's a problem of, I think part of it is also a problem that is sort of self-inflicted by Nigerians, because Nigerians are not prepared to hold their public officials to account in this area. So I think this is an important speaks to this issue of equity that has sort of featured prominently in my intervention.
Okay. Lastly, before we let you go, even as we begin to wind up right now, recently, government, the president, over the weekend, there was an announcement that he had approved the construction of 8,800 PHCs, primary health centers in Nigeria. But I believe you understand the Constitution. The Constitution, I believe, positions primary health care under the local government and states. Is it right for the federal government to get into such an investment right now? Shouldn't that be the responsibility of the state for us to hold the states and local government responsible for that?
No, absolutely not. I would say that the president is doing the right thing. This is because there are other countries where, for example, South Africa and India, health is the responsibility of all the arms of. Okay, in India, for example, health is the responsibility of the states, but the federal government often intervenes. In South Africa, all arms of government have obligations in health. Now, even though the Constitution says primary health care is under the local governments, it does also involve some responsibility for the federal government as well. The federal government has equal obligations or responsibilities in the health system. So it is not entirely the case that only the local governments or the state should be responsible. The other point you need to really consider is that, look, the arm of government with the most amount of access to funding is the federal government. If you isolate the federal government from responsibility for health, just because the Constitution says it's the responsibility of the states or the local governments, what you're doing is you're essentially having that go to the community that is going to be starved because nobody is going to be responsible for it. Another point to add is the Basic Healthcare Act. The Basic Healthcare Act, which I referred to in the National Health Act, which I referred to in my intervention, talks about the Basic Healthcare Fund. Now, if you read that act carefully, you'll see that what that act does is that it vests responsibilities on the federal government to take action in the context of health. Now, the basis for the government having the ability to do so is because even though I mentioned that Chapter 2 of the Constitution of Nigeria provides that the right to health is not justiciable, what that provision does say is that the federal government should take necessary action, including legislative action, to strengthen the healthcare system. So, having taken legislative action in the form of the National Healthcare Act, where the act is imposing obligations on the federal government to take action in the health system, it means that the federal government now has responsibility for health. And so what the president has done in establishing 800 primary healthcare centers, as you have said, is the right step. It's a step in the right direction. It is some modest progress, but more can still be done to strengthen the health system.
All right, let's go to Dr. Oshundara Tokwe-Zenith right here. You started with him. We'll be wrapping up with him right now. And we once again want to apologize that we had to go off Facebook and we had to restrict the amount of access we had to this link is to prevent further hacks. But this conversation will definitely be live on social media immediately after this webinar wraps up in just about 5 minutes. So, Dr. Oshundara, you listed a couple of to-dos during your presentation, but my question to you is, what is the biggest need of Nigeria right now? Is it a case of, do we need expertise to be in the sector? Do we need more funds or better incentives for the practitioners, or do we simply need to do a lot more of what I'll call getting proper tooling, more equipped hospitals or health facilities and all that? I'd like you to respond to this, but just before you do that, let's take this short break, then we'll come back to you in just 1 minute. This is the April Health webinar, and we'll be right back. Don't go anywhere.
Now, what for this country? Everything just cash, even cash. KC, I don't define you for shops this morning. Why you take this kind of cute? Jojo, now cash I want collect since morning. Cash? Why? I know one waiting happen for 1672 happen again. Today, I must collect correct ladder note for hand. KC, cash there everywhere for bank, ATM, POS agent, and if you want run and cashlessly, you fit use mobile app, internet banking, ATM, POS, USSD, QR code, and other options them. Dudu, you sure? I beg you, make we then go. Your customers they shop, they wait for you. See, the cash where you define for Sokoto, there for your Sokoto. You understand? Country people, money na money. Spend time, collect time, no hold down, no panic. Cash there everywhere. This message now from Bankers Committee.
Nice. All right, welcome back right here. This is the Lagos Talks 91.3 FM. It is the April Health webinar. The beginning of a month-long activation discussing health-related issues, resolving complications, because you know that a lot of panelists or resource persons will address issues that pertain to your health, which some of us might be grappling with, or even issues or health concerns we never knew we should have, or concerns we never knew we should have about our health. So I will get into that. Dr. Oshundara Tokwe, are you there with us? Can you hear me?
Yes, I'm with you. Can you hear me too?
Yes, great.
Welcome back.
Thank you. Yeah, that's it. So just as we wrap up right now, what is the greatest need? Is it more equipment to work with, which means retooling the hospital and everything we have? Is it capacity of the personnel that requires boosting, or is it more of incentives? If there's anything government has to do immediately, what would you advocate for?
Well, to start with, I would want to say that everything is interwoven. It is important to give incentive to the health workers, and it is equally important to train and retrain those who are on the field. But most of the time, somebody has also mentioned during the course of discussion that the political will is always the problem. In this country, there was an Abuja declaration in 2001 that says 15% of our budget should be allocated to health. And what we've seen over the years, this same declaration that involved all the African Union happened here in Nigeria. And the Nigeria that where this declaration was made, it's not even adhering to what was declared in 2001. So we still have very far less than what the declaration says, which has been affecting the health funding. Dr. Uche mentioned the other time that the involvement of government cannot shy away from funding for health, irrespective of where other sources of funding will come from, either private sector or state government or local government. It is important that the federal government that has the bulk of this allocation should fund health, which
will provide more incentive to health workers. If they fund it properly, it will also enable those who are in service to go for training in different fields or in different specialties. So it is important, if you have the equipment, if you retool, buy all the the sophisticated medical equipment, state-of-the-art equipment, or you build the state-of-the-art facility in a place like Lagos, but you do not have adequate manpower, it becomes a problem. After a while, those things will rust, wear and tear will happen. In fact, there is this thing we call in medicine atrophy of disuse. After a while, when you have neglected this thing, they become redundant. So many things rust, so many things will happen because you are not servicing them properly. So it is important that, as much as we are saying that we want technology, now we have AI and we have so many other technology to aid medical, medical work or the services we render in health. As much as we have all of this technology, we should also consider that those who are going to be using this technology, those who are going to be using this tool, must be properly educated, properly trained, and they must be motivated to work. And that is where the incentive comes in. So you cannot say go and do something without providing adequate incentive. And I mentioned during the course of my discussion that the incentive you are providing must be adequate and it must be attractive. So these things are interwoven. And unfortunately, we have had leadership failure, which like the pastor yes, when he was mentioning, Dr. Uche also mentioned that equity, when there is no fairness, you have two people in a family and you are treating one like is the golden boy and the other you neglect. So if there is no equity, no fairness, no justice, you are about to have all of these things that is happening within the health system. So the leadership failure stemming from the top to the bottom table tier of leadership, it has been the bane to the healthcare system in Nigeria.
Thank you. Thank you, Dr. Oshundare Chokwe-Zenith. And as we wrap up this conversation, I know the bigger chunk of the conversation has been around funding. So you have mentioned that incentivizing doctors and healthcare workers is just the way to go. Was it Pastor Peters Omoragmo that made mention of maybe some of these foreign companies that use Nigerian doctors should also start to fund training,
the countries, yes,
and the training of Nigerian nurses, the training of Nigerian doctors? Is it something that you feel can also help here? If we can get some of these countries to also invest in the healthcare sector here, get money from them as well to add to what we have here to better the standard of living of doctors and nurses here. Does that work?
Yes, it is going to work. At some point, the federal government is also working with doctors in diaspora, especially in America. The Honorable Coordinating Minister for Health is trying to bring them down to Nigeria so that there can be adequate training in various fields of medicine. Rather than travel out of the country, what we are trying to do now is to have those things done inside.
Okay. Okay. You just went mute. Can you unmute yourself, Dr. Oshundare? Dr. Oshundare Chokwe-Zenith.
And Dr. Oshundare, just so we're sure that you get the point, what I'm just trying to say is that if you have a situation where if any country is in need of nurses or doctors from Nigeria, can we at least build them? I mean, just as you alluded to the other time, the Nigerian government has invested some amount of money in training the doctors that we have here. No matter how little or how we say it, some investment has gone into them. When we have other countries benefiting from the knowledge that has been, the seed of knowledge that has been sown into them, should we begin to build them for it? I mean, for you to have any doctor or any nurse from Nigeria, pay this amount of money or invest this amount of money into training the ones that are here already, or into, paying the ones that are here already.
Yeah.
That's the point I'm trying to make. Do you see?
Should we begin to build?
Like all countries like the UK that will need Nigerian doctors, should we begin to charge them maybe a fee that, okay, for you to take Nigerian doctors, this is what you should do. She's referencing what, was it Pastor Muragmo said, that countries like, was it Pakistan and co and Saudi Arabia, they sponsor doctors in Kenya. So when they need doctors in their place, it's easier for them to get doctors from Kenya to those places.
Yes, they've invested before
Yes.
you can even build them. So that there is an investment. But some of this country, Nigeria is not even creating, the platform for that investment. That's what I'm saying. So you cannot levy something on someone who you've not even given opportunity to come and invest in your country. How many of those foreign countries have come to Nigeria to invest? Virtually none. So before you can even have that audacity or moral rights to go and tell them to do something, then you must have created a platform. If they are not now making use of it, you can now revisit your policy and all.
But a quick one here, Dr. Oshindara. If you say Nigerian doctors are well sought after, our medical practitioners, maybe nurses and all other players in that field, but why aren't we seeing this offer from these countries saying that, okay, since you have a huge population, I want you to work with you to incentivize nursing so that or medicine so that a lot more Nigerians will go into it. And when they come out, I'll take this number of your people away from you. You keep the rest. Why are we not attractive enough, or what have we done wrong?
Well, please don't limit our knowledge to Nigeria alone. Of all the countries abroad, in some of the developed countries, it is not only Nigeria that is doing well in terms of medicine and have a large population. The Philippines, the Pakistans, the Indians are there. And these guys are very brilliant. As in, when you say people are very brilliant in the field of medicine, you give it to them. They are very, very vast and good. And when it comes to writing all of these foreign exams, they might to be one of the best when it comes to foreign exams too. And some of these countries like Pakistan, Philippines, India, they make sure to provide opportunities for their doctors, their nurses and health workers, so that all these countries will see them or find them attractive. But in Nigeria, it is self-effort that has even projected most of us to the outside world. It is not the country. So what you are saying is Nigeria, they are good, they are this, and people should begin to pay for that brilliance. Of course, if they are going to pay for the brilliance, the payment will not be to the country, to be to the individual who has made himself available through training or who has acquired more knowledge. You know what people go through to get information, what people go through in this country to have adequate technical know-how. So when you want to pay them, you now pay them. It is not the country that finances. If you are going for a postgraduate study, it is not the country that is going to finance you. Most of the time, you do it on self-effort from your own out of pocket. So if there will be anything at all, look at what the nurse was saying, rather. He was talking about people leaving the shores of the country, writing this exam. Is it the government that is paying for the exams? No. So if the government is going to benefit anything from it, then they should make the platform available. So that when this platform is available, then people now can begin to pay for the services. So that's my own take on it.
Okay, thank you so much. Alalo. All right.
Let's just take this contribution.
Yes, we're only taking one contribution because we were meant to end at 1 p.m. but due to the middle mix-up and all that, we've extended it now till 2 p.m. So let's just take this.
Yes, this one came in via WhatsApp. Our government would rather demand the fund and spend 10% and pocket the remaining money. A VFCC can invest the funds and realize they realize from the looters into our health sector, it will be good. That's I believe what Dr. Oshindara is saying is that it takes a whole lot more than what the government invests in a doctor to actually be attractive to countries like Canada and UK. And even on the outside, competition is quite, it is quite huge. I mean, while you may pride yourself in being a Nigerian doctor, you know this, you know that. There are people from Pakistan, there are people from the Philippines. They've had access to even better training
facilities.
Yeah, they even look more attractive. So if you want to come up with a class of, you have to pay my government before you can take me. I mean, wouldn't they rather go to some other countries and pick other people? I don't know.
Remember I mentioned that there are also plenty. They are more. In fact, you have a whole lot of them in some of these foreign countries. It's not Nigeria alone. If you go abroad, you will always find, among all of the blacks, you find Indians, you find Pakistanis, you find.
All right. Yeah, interesting insights. And unfortunately, or fortunately, I don't know where you sway. We need to call it a day. It's been how many hours now? 3 long hours since 11 o'clock that we started. And it's just, what has it been like for you?
Interesting. I mean, I've found this really, really interesting. I just wish that our government officials will have the political will to implement some of the recommendations that have been put forward.
Yeah.
The recommendation from, Dr. Oshundare to Pastor Peters.
Yes.
Omoragbo to Dr. Uche Ngwaba.
Yeah.
I mean, it's been spectacular. And as we put this content on our social media spaces, I want to implore you to look out, because we'll cut them in bits and put them out there from time to time. We even have to have interesting conversations on some of the points that have been made, because if we say we look into some of the points that have been made, I mean that's like a whole topic, a whole interesting topic on its own. So I just look forward to having people listen more to this, having government officials also listen more to this and build that political will to make things happen. For me, I think it boils down to us actually having a government that cares about the standard of living of Nigerians. I mean, recently a government official was talking about how 1,500 naira is a lot. I mean, those are the kind of people you expect to incentivize doctors, people who have access to funds to go treat themselves and their children out abroad. Yeah. So I mean, for me, political will continue to happen these days and have these conversations until we get to where we ought to be.
Yeah, that's it. And quoting Winston Churchill, former Prime Minister of the UK, says healthy citizens are the greatest assets any country can have. And that is not different about Nigeria. From sports, it's people, to music, it's the people. Imagine all these people were unhealthy and were looking scrawny. Remember the days when Nigeria or Africa was seen as the place where people who are malnourished. Is because of the people, not the nation Nigeria. It's the people that make the nation. So a healthy citizenry is more of a healthy or a wealthy nation. Maybe that's a good place to end it.
Maybe it's a good place. Health indeed is wealth.
It is wealth.
The health of a nation is the wealth of the nation.
That's it. That's it.
I got that from a professor from way back in uni, Professor Rao Pakitele.
Okay. The health of a nation is the wealth of a nation.
It took us health journalism, and he would always say that the health of a nation is the wealth of the nation.
That's it.
I am Olaoluwa Aweth, the news lady.
And I am Iposu Elijah Oluwa Kayode.
Thank you once again for listening.